Okay, so this is the cardiology section. Let's do this. Question number one. A 66-year-old man comes to the physician for a routine health maintenance examination. On physical examination, his lungs and heart are normal to auscultation. He has a 40-year history of one pack of cigarettes per day. A CT scan of the chest shows the tumor invading the pericardium, labeled A. Biopsy of the mass shows well-differentiated lung cancer. Which of the following structure is most likely compressed by the tumor? Structure compressed by the tumor. Okay. So they're asking about which structure is compressed by the tumor. Let's highlight that. This, which makes it strictly anatomical question. Structure compressed by the tumor. Let me color the tumor with green. This is the tumor in this picture. I colored it green. So this tumor is compressing the right side of the heart. How do I know this is the right side of the heart? You see the heart is more on the left side, so this side would be the left side, right? Okay. So where is my... This is strange. What's going on? I can't even see my arrows. Okay. All right. So that's what we're going to do. We're going to try to answer this question. One thing I want to do is this, so I can use my arrows. Okay. So strictly anatomical question. Now, for us to understand, you know what? I need to make this picture bigger, so we can see where everything is. How do I do that? Can I use this to make it bigger? Maybe this one. Yeah. No, this is moving it. Let me go back, fix it. There should be maybe this one. There you go. Okay. So I'm going to make this bigger for us to look at this CT scan, and we can identify the structure we want to do. Okay, change my color in my pen. This structure is aorta. Okay, right here, so in front of the aorta, between the heart and aorta, here should be like a collapsed structure called esophagus. I'll label it esophagus. On each side of esophagus, let me use green, would be vagus nerve. So this green. I'm sure you guys can see that on my picture because I can see, so you guys should be able to see it. So that's vagus. Okay, I'm coloring it, maybe change color. So yeah, this is vagus. These are vagus nerves on each side of esophagus. Aorta is labeled A. And maybe I can even color it aorta A red. So there you go. This red structure is aorta. Okay. If that's the case, that means I should be able to color esophagus more of a yellow structure. Yeah, let's do that. This is esophagus. See this yellow? Okay, on each side, green is vagus. Let's choose blue. So this will be, so on the right side right here will be the esophagus vein, blue. Can I make it better blue? Yeah, let's see if this one is better. Blue. So this blue is esophagus vein. Okay, maybe somewhere in there, let's use orange, although it should be green because I think of thoracic duct as being green. So here somewhere should be thoracic duct. Okay. Okay. Let me change thoracic duct color to different. What color should I choose? Let's choose yellow, bright yellow. Okay, so this yellow would be thoracic duct. So these are the structures that are related because the question was talking about some of these structures. So that's here. And sympathetic chain would be right here. See this sympathetic chain on each side. Output chain Okay, so sympathetic chain. And then if you were to divide the heart, maybe yellow would work, yeah. So this is the interventricular groove between the two ventricle. So all of this is the right ventricle. It's not good. Let's change color to blue. So this is the right ventricle. Okay, right ventricle. Here is the right atrium. Here is the left ventricle. And this is the left atrium. Okay. All right. And between this area, this is the interventricular groove, and that's where you will see the coronary arteries, right? Okay, the left, at least the left anterior descending coronary artery. Okay, so what I'm going to do is I'm going to take this, make it smaller to see if it answers our question. If that was helpful, so we identified some structure for our simplicity. There you go. Okay, now we're good. 1-to-1 ratio, good. Okay, so in this question they want to know what structure is mostly compressed by the tumor. So by the tumor, coronary sinus is posterior to the heart, so it will be somewhere right here. Okay, so it's unlikely, so no. I'm going to use red. Coronary sinus will be right here, right along the between the two, is between the atrioventricular groove. That's where this will be. Posterior will be somewhere here. You see this line I'm drawing? I'm going to erase this. So that's where it would be. So that's unlikely. Greater splanchnic vein will be right here, be closed in this area that I'm coloring red. Okay, so that's unlikely. Phrenic nerve is right here, so one is on each side of the heart. Okay, so phrenic nerve, yes, definitely. I should have drawn that before. So red, the one I'm coloring red right now, that's phrenic nerve. See, next to green, this red dot, that's the phrenic nerve. It's not that big, but that's just doing it so you can see it. So yeah, the answer should be phrenic nerve. The answer should be phrenic nerve. Vagus nerve, remember we said vagus nerve is next to the esophagus right here. I label in the picture right behind the heart. So this arrow, okay. So no, it's not vagus nerve. Thoracic duct was this small next to aorta, so that's not it. So our answer should be very simple, straightforward anatomy question is the phrenic nerve. Phrenic nerve is related to the right atrium and right ventricle. It's on each side of the heart. It's more anterior, it's not so much posterior. It's in the structure, all these other structures of the posterior mediastinum. Only phrenic nerve is in the middle mediastinum. So it would be the right phrenic nerve. So let's say in this question, I change it and I put right and left phrenic nerve. So then you will choose the right phrenic nerve, okay? Because the structure is related to the right side of the heart. So that'll be the quick answer. So you should know your anatomy. Structure of the posterior mediastinum are really important. Posterior mediastinum will be aorta. Okay. Again, I showed it in the picture previously, so look at it again. Esophagus vein, thoracic duct, vagus nerves. Okay, vagus nerves. What else is left? Sympathetic chain. All these structures are behind the heart. Sympathetic chain. Okay. And whatever else I'm missing. So these are in the posterior mediastinum, middle mediastinum. Middle mediastinum. Of course, the heart itself and its structure like pericardium. Also, we will have, for example, in this case was coronary sinus will be there, right? Coronary sinus. And then we have the phrenic nerves. So these would be the middle mediastinum. mediastinum. Okay, so look for those things. Superior mediastinum is a bowel. That's all the structure can be the superior mediastinum. Okay, so hopefully this was helpful. So this question is very straightforward. Um, the person most likely had lung cancer and is telling you, but it's not about lung cancer. The question is about which structure is compressed by the mass, in this case labeled A, which is a lung cancer. Okay, let's go to next question. Okay, so this next question is, let me get my highlighter, choose green. A 68-year-old woman is brought in emergency department because of severe chest pain, diaphoresis, and shortness of breath. She has a 6-year history of stable angina. Pulse is 120 per minute, respiration is 16 per minute, and blood pressure is 120 over 80. EKG shows ST elevation in lateral leads. Plasma, troponin, and creatine kinase MB levels are elevated. Which of the following is the most likely cause of these laboratory findings? Okay. For me to answer these questions, I think it's best to diagnose what's going on first. So, 68-year-old woman, she's postmenopausal woman. Remember that usually for the purpose of USMLE, premenopausal female are unlikely to get a heart attack or myocardial infarction because estrogen is protective. It is only after postmenopause that female and male risk of myocardial infarction is the same. Okay, so come to the emergency department because severe chest pain. Whenever I see severe chest pain or any chest pain, I will think of heart attack first, diaphoresis, sweating, and shortness of breath. Typical signs of heart attack or angina. She has a 6-year history of stable angina. There you go. So if she has a history of stable angina, now she has this pain, and it's not telling you that this pain is during rest or exercise. So I'm going to assume it's in rest. Pulse is increased, respiration 16, blood pressure is normal, there's ST elevation. Okay, so if stable angina will have ST depression. Because it's ST elevation, I'm going to think unstable angina. And plus, so there's two things that they don't give me, and I'll write it down once I tell you. Two things. If they give me the chest pain was induced by exercise, activity, jogging, walking upstairs, downstairs, any sort of activity or stress, and ST was depressed, I'll think of stable angina. Because they don't give me those things, then I'm going to think of unstable angina. Okay, plasma troponin and creatine levels are elevated. There you go. It's no longer just angina, it is MI. Okay, it is MI because the enzymes are elevated. These are going to help me. So, you know what I'm going to do? I'm going to do this. Let's say what's the difference between angina and MI. Okay, both will have chest pain. Both will have chest pain. In both cases, chest pain is severe and it's substernal, it's non-positional, and it radiates to the left jaw and shoulder, and it's accompanied by diaphoresis or sweating. Because angina is just on a spectrum. Angina comes first and then MI. Any angina can lead to MI. Diaphoresis. It simply depends on how long is the ischemia, right? And there's shortness of breath, or I would say dyspnea, right? Dyspnea. So these are typical signs of angina or heart attack regardless. Okay, so as I said, in addition to that, ST elevation in both MI and in unstable angina. Let's just make this for now unstable angina. Unstable and variant angina both gives you ST elevation. It is the stable angina that give you ST depression. Now, how do I remember that? Look, stable ST under the table. Stable ST under the table, meaning ST is depressed under the table. But in this case, ST is elevated, so I'm going to think of unstable angina or MI. Okay, so what is the difference between the two? It is the troponin, cardiac enzyme. Troponin is normal. Troponin is normal in angina, and they are elevated in myocardial infarction. Okay, all cardiac enzyme. Let's say creatine kinase, MB, normal in angina and elevated in myocardial infarction. In our question, let me get my highlighter. In our question, we see that these are elevated. So I'm going to choose my diagnosis is MI. Okay. So my diagnosis is MI. Now the question is telling you which of the following is most likely the cause of these laboratory findings. So what are the lab findings? The lab findings are, they're talking about the troponin. Okay. Lab findings are troponin. Why are the troponin elevated? Why are the CKMB elevated? That's the lab finding. Okay, because there's no other lab finding that are given to us. EKG is not a lab. So they're talking about lab finding, which is a plasma level of troponin and CKMB. What could be the cause of that? Simple question. So first we diagnose our condition is myocardial infarction. You know, in myocardial infarction, there is lysis, damage to myocardial cells. So let's draw a myocardial cell. There is a myocardial cell. Okay. A myocardial cell. Yeah. Okay. A myocardial cell. Okay. So the myocardial cell. Uh-oh. Let me do this. Change this here. And quickly. So that's my myocardial cell. If we pay attention to a myocardial cell, remember the myocardial cells will have, it's full of enzyme. I'll put T, troponin, and it's full of CK and B. Okay. So the only time when this cell gets damaged, you can find this enzyme in circulation or in plasma. Only when it's damaged. If it's not damaged, then no, it's not going to happen. So in the case of myocardial infarction, obviously the myocardial cells, they get damaged. So when these cells get damaged, their content will be released. So let's do that. There you go. The cell bursts and its whole cytoplasm will leak. When the cytoplasm leaks, then you will find the enzyme floating in your plasma. Okay. As long as the cell is intact, its membrane is intact, then you will not find this enzyme at a higher concentration. So only then I'll find T and CK in plasma. Okay. All right. So let's see what are the choices. The choice increase Golgi complex activity. So they're saying is what is the cause? Let me highlight that for us so we don't forget. Which of the following is the mostly cause of this laboratory finding? The cause of the laboratory finding is, so they're asking you what is the cause, and choice A tells you increased Golgi complex activity. Well, Golgi complex activity, remember Golgi, all cells have Golgi. So let's say there's the nucleus, around the nucleus you have the rough endoplasmic reticulum, and then the endoplasmic reticulum is attached to Golgis, and Golgis have these vesicles that release their content or protein into outside or inside. Okay, so Golgi is nothing more than an organelle that packages vesicles or protein. So whenever new proteins are made by the ribosomes and the endoplasmic reticulum, then those proteins are packaged within vesicles by Golgi. So Golgi does two things: packages these vesicles, okay, newly synthesized protein are packaged by Golgi, and then they put a stamp on them. Sort of an address. Whenever you package something, you want to send it somewhere, you want to put an address on it, and this address will tell you should this package or this protein reach a cell membrane, should it be secreted outside of the cell, or should it be sent to the mitochondria, and blah blah blah. So it is unlikely. Remember that Golgi is responsible for packaging proteins and putting a label on them, but it's not responsible for increase in the case of these enzymes being released into the outside of the cell, because the enzyme purpose is inside. So that's not an answer. A is not a good answer. Increased plasma permeability. Obviously, yeah, should be the best answer. B. For now, I'll choose B because troponin and CKMB are within the cytoplasm of a myocardial cell. So when this cell bursts or it damages or its cell membrane gets damaged, as is in all myocardial infarction or ischemia, then this enzyme will release and it will increase in plasma. Okay, so far B. Mitochondria swelling and loss of function. Look, mitochondria doesn't have troponin CKMB, so whether they swell or they have loss of function is not going to affect troponin CKMB level. If anything, mitochondria has within them pyruvate dehydrogenase enzyme and electron transport chain enzyme responsible for production of ATP. When the mitochondria is damaged because of myocardial infarction or ischemia, that means initially the damage happened because you're not having enough ATP. If you don't have enough ATP, your cell switches to glycolysis. Glycolysis is unable to maintain uh, myocardial function more than 30-40 minutes. So then they go through death or damage. So if mitochondria is damaged, that means even if you have circulation and oxygen availability, it won't be able to produce ATP. So mitochondria, if anything, will be more for ATP production. Nuclear lysis and chromosome disintegration. Again, nuclear. So troponin and CKMB are not enzymes found within nucleus. They're cytoplasmic enzymes. So damage to the nucleus or chromosome will cause DNA problems, right? You will not be able to make new protein, new troponin and CKMB, but it wouldn't be responsible for the release of existing troponin and CKMB. Proliferation of endoplasmic reticulum. If the endoplasmic reticulum proliferates, again, this will indicate that you're making more proteins or more lipids. There's two types of endoplasmic reticulum: smooth endoplasmic reticulum and rough endoplasmic reticulum. Smooth endoplasmic reticulum is responsible for steroid synthesis, lipid synthesis, and detoxification of drugs, whereas rough endoplasmic reticulum is responsible for synthesis of proteins. In either case, it would not be the cause of existing enzyme release. It would be only responsible for making new proteins, and that's only rough endoplasmic reticulum. So once we know this information, we know clear cut that our answer is B. Why? Because these enzymes or these troponin, CKMB, they are cytoplasmic proteins. Cytoplasmic proteins. Okay? Troponin is a huge component of striated muscle. Remember, it's responsible for contraction of striated muscle. It binds troponin C, binds calcium. There's troponin I, troponin C, troponin T. Three components to it, right? So if you want to know the details. But anyways, our answer is B. Hopefully that makes sense. Let's go to our next question. Okay, so this next question, let me fix my page. Yeah. So this next question is about a 30-year-old woman comes to the physician because of a 10-day history of fever, fatigue, and murmur. Recently, she had a root canal procedure done, prior to which she received a single dose of amoxicillin prophylaxis. Blood pressure is normal, pulse is high, temperature is high, and there is a murmur. So 4 out of 6 blowing murmur is heard on auscultation in the left fifth intercostal space. A gram stain of the blood culture is shown on blood agar plates. The organism shows alpha hemolysis. Which of the following bacteria is most likely the cause of this patient's condition? Okay, well, it looks like we are talking about endocarditis, but let me see. If I expect endocarditis, what would I be looking for? Endocarditis. So this is first, let's diagnose, then we answer the question. So the question is talking about endocarditis. In endocarditis, this is what I expect. I would always expect fever. I would always expect rash. You know what? Let me do murmur first and then rash, because rash has components to it. I'll always expect murmur, and then I'll expect a rash. So these three makes me suspicious that it is endocarditis. So I become suspicious that this is endocarditis. If I'm suspicious, what do I do next? Blood culture. Blood culture. Okay. So blood culture, if it's positive, this is 100% endocarditis. And let's see if we have these things. Okay, so I'm going to highlight for us. She's a female. She's a 30-year-old woman who came to physician. So she came because of fever, fatigue, and murmur. So there you go. At least these two criteria are met. So there's fever, there's murmur. Recently, she had a root canal procedure done. Okay. prior to which she received a single dose of amoxicillin prophylaxis. Blood pressure is normal, pulse is high. Okay, so that's usually an endocarditis. Temperature is high. Again, this is the fever component. And there is a blowing murmur heard on auscultation in the fifth intercostal space. Most likely we're talking about mitral valve. A gram stain in blood culture is shown right here. So the gram stain is positive. Look, blood culture, gram stain, positive. So for me, this is 100% endocarditis. Blood agar plates. On blood agar plates, the organ shows alpha hemolysis. Okay, which of the following bacteria is most likely? So first we diagnose, we know this is endocarditis, and the only way we can get endocarditis is if a bacteria gets exposure or access to endocardium. Okay, and when you want to think of endocarditis, to be honest with you, keep it simple. The best way to think of endocarditis is valvulitis. Valvitis or valvulitis. So it's infection of the valve. Okay, so valve infection. Because the rest of the endocardium doesn't produce symptom, it's the valve. In this case, it is the valve that's infected is in the fifth intercostal space, so most likely it is mitral valve, and most likely in this, what is the murmur? Blowing murmur is heard on auscultation, but it doesn't tell if it's systolic or diastolic. So maybe regurgitation. Let's just think of it as regurgitation. Initially, the first complication of endocarditis of mitral valve is regurgitation, and then with long time, it becomes stenosis. Okay, so first regurgitation, then it becomes stenotic. Irrelevant to this question. So we know this is endocarditis. Now that it's endocarditis, we want to know, the question is asking what's the cause of this endocarditis, and let's see if we can identify it. Okay, we want to identify the exact cause of this endocarditis. So which of the following bacteria? So what bacteria is most likely the cause of this condition? So what do we need to know? Because the bacteria, it's telling the bacteria is alpha hemolytic. Okay, and this person had a dental procedure. Dental procedure. Dental procedure. So risk factor for this infection is dental procedure. So that's one. And then the bacteria that is there is alpha hemolytic. Alpha hemolytic means partial hemolysis of red blood cells. It doesn't mean complete. Okay, partial hemolysis. So it causes the bursting or fracture or lysis of red blood cells, partially, not completely. So as a result, you will get green zone on agar. So on agar, you get a green zone. Okay, so that's partial hemolytic. There's only two bacteria that are partial hemolytic. Number one is strep pneumonia. So I'll just tell you for now, strep pneumonia and strep viridans. So two of them that are alpha hemolytic. So it's strep pneumonia and strep viridan. Okay, now let's see if, so at least we have in our question we have those two, right? We have strep pneumonia, and then we have strep viridans is not here, but it's a strep viridans is a family. One of its component, one of its member is streptomyces. Okay, streptococcus. So what do you see on the gram stain? On the gram stain, we see a chain of round cells, gram positive. So this tells me this is gram positive because it's stained blue or purple. Gram negative will stain pink. So this is gram positive bacteria. It's coccus. Why? Because it's round cells. It's not rod or bacilli. So therefore it's streptococci, right? Streptococcus. If it was staphylococcus, staph is cluster. So I'm going to erase at least let's get rid of C. Staph aureus would be cluster. So all those ones that are coccus are in chains. So these cells that you see in this picture are in chains of round cells. So these are all streptococcus. Staphylococcus will be cluster of cells. I'm going to draw it right here. Look, cluster. This is cluster. This is cluster. Okay. Chain is in a straight chain. Round cells in a chain is strep. Round cells in cluster is staph. So I hope you differentiate between the two. It's very easy. Staph and strep. Okay. Now I'm going to go with Streptococcus pneumoniae. Streptococcus pneumoniae is usually diplococci. Diplococci or Diplococcus, which means these are round cells in pairs. In this picture, I don't see pairs. I see a linear chain, a long chain of multiple round cells. So Diplococci, so as a result, already I'm thinking it's not Streptococcus pneumoniae. The second thing is Streptococcus pneumoniae causes pneumonia. It's unlikely to cause endocarditis. Okay? Rarely. So that's one. And Streptococcus alpha hemolytic. Okay. Now I will give you the characteristics of this. Streptococcus is exists in Diplococcus alpha hemolytic. In addition to that, it is um, I don't think the rest even matter. Novobiocin, and it's sensitive to salt, and it dissolves in salt and dissolves in bile, and those things. Streptococcus mitis is not Diplococcus; it's chain. It's many of them, so it's a chain of cocci, chain of round cells or cocci. In this case, that's what we see. So I'm going to go with D. But streptococci also, the risk factor for streptococci to get endocarditis dental procedure, which we have in these questions, and it's alpha hemolytic. So everything matches streptococcus mitis, hemolytic, alpha hemolytic. So these two criteria matches that, and streptococcus pneumoniae doesn't cause endocarditis. Okay. Now, so just as far as right now we're concerned, our answer is Streptococcus mitis. So I'm going to choose that. But let me go further, explain the other ones. Enterococcus fecalis is also streptococci in chains, and these ones are usually the risk factor is like GI procedure or urinary procedure. So that'll be the major risk factor for them. So if a patient comes with colon cancer and they do under colonoscopy or they do other procedure where the intestine is disturbed, the normal flora of intestine is disturbed, this can put you at risk of endocarditis. And enterococcus is gamma hemolytic. It's non-hemolytic. How about that? It's non-hemolytic. It's resistant to bile. It doesn't dissolve in bile, and it's resistant to salt. So that's how you can differentiate it from others. Whereas Streptococcus pyogenes is the cause of rheumatic fever, rheumatic heart disease. Remember, Streptococcus pyogenes is Streptococcus. It has a capsule, but it's beta hemolytic. So beta hemolytic, not alpha. So that's unlikely. And then Staph aureus. Staph aureus, the way you should know, it's called a superbug. It is beta hemolytic, but it doesn't exist in chains. It exists in clusters, and it is catalase positive, coagulase positive. So those are the things that will help you. Okay, so hopefully this was helpful. First, we identified this was endocarditis. The next thing is we have to identify what's the bacteria. We're looking for a bacteria for which dental procedure is risk factor, and it's alpha hemolytic. The only one that matches this criteria is Streptococcus mitis. Okay, and of course, Streptococcus mitis is a member of Streptococcus viridans. Viridans. Okay, and this bacteria exists in the oral cavity, causes dental plaques, and so forth. Okay, so hopefully this was helpful. Let's go to our next question. Okay, so next question, let's read this. This question is talking about a 22-year-old man comes to the office because of a 6-week history of exertional shortness of breath and fatigue. He takes no medication and has not seen a physician for several years. He is 5'10" and 154 pounds. BMI is 22.1 kilogram per meter square. Vital signs are within the reference range. The lungs are clear to auscultation. Cardiac examination shows a normal S1 and a widely split S2 that does not change with respiration, in a grade 3 out of 6 holosystolic murmur that is loudest at the lower left sternal border and radius to the upper left sternal border. EKG is shown. Which of the following is the most likely cause of this finding in this patient? Okay, so for me, this is a clear-cut scenario of ASD amongst the choices. But now, let's see, what are we looking for when we think ASD? So let me go here. ASD, atrial septal defect. So number one, atrial septal defect is symptomatic. It becomes symptomatic in adults. Okay, so when the demand for circulation increases. So number one, it's an adult, whereas VSD is in children. So that's one thing. Next thing is in ASD, I expect in ASD there to be a murmur. The murmur is usually systolic ejection murmur. Okay, so systolic ejection murmur. Or you can say pansystolic. It's because it's throughout the systole, or holosystolic, same thing. It's ejection because it's the murmur is primarily produced by the pulmonary valve. Okay, so I look for murmur. Maybe I should say murmur first and explain what kind of murmur. Okay, so I'm looking for a murmur. Additionally, I'm looking for S2. You know what? I'm going to erase this just to tell you then what. So number one, I'm looking for symptomatics in adult, and then I'm looking for murmur, and then I'll be looking for abnormal S2. Okay, so that's 1, 2, and 3. Sorry, 4. I'm looking for right bundle branch block, and number 5, I'll be looking for volume overload. Volume overload, or signs of volume overload. Let's see if we have these things. Okay, so number one, we have you know what, let me do this. So the murmur should be systolic, and it's usually ejection because it's the pulmonary valve. Okay, so the murmur is systolic ejection murmur. And where would you hear this murmur? So if it's pulmonary valve, I'm going to say you hear it best at the second intercostal space. Second intercostal space, ICS, intercostal space, left of sternum. Okay, or I should say, let's do this. Left upper sternal border. That's where I would hear it. Okay, left upper sternal border. So that's for this. And then S2. So the S2 is abnormal. What does it mean? Number one, it's widely split. Widely split. Okay, so that's one thing. And then it's fixed. Fixed mean it doesn't vary with respiration. Okay, and then I'll be looking for right bundle branch block, which in this case EKG is shown. So how do I know RBB? You can only see that on EKG. On EKG you will see rabbit's ear, or the R wave. R wave will be split, double R wave. So you will see something like this. So imagine this is the R wave. Typically you will see in EKG P wave, Q, R wave, S, and then T. So this is the P wave, this is the R wave, this is the S wave, this is the T, and this is Q. I should put small q, but anyways. So let me highlight the R wave for you. This is the R wave in green. Imagine I'm going to change it to red, so you can see if this R wave is now double like that. Okay, and it represents the right bundle branch block. See the right bundle, so electric impulses come from the AV node to bundle of His, and the bundle of His was split into two bundles, the right bundle and the left bundle. The right bundle will supply the right ventricle, and the left bundle will supply or innervate or put electric impulses to the left ventricle. If the right bundle is the right bundle then split into two, right? The right bundle, this the right bundle, this the left, and if the right bundle will then split into two, or go into two branches. If one of the branches blocked, then you will see a double R wave. Okay, that's what it, because of that block, because that means the ventricle is not contracting exactly the same time. Different parts will be different. Okay, so look for that, and I see that. So for me, this is ASD. So let's see if we have evidence of this in this question. So number one, this person's adult. Yeah, And next thing we look for murmur. So this person had a murmur. Where's the murmur? Right here, grade 6, holosystolic murmur. Loudest at the lower left sternal border and then radiates to the upper sternal border. So I told you that murmur you will hear most likely in the second intercostal space, left upper sternal border, which is the pulmonic valve, increased blood flow to the pulmonary valve. Okay. Okay, next thing is, so murmur is done, adult is done, and then we're looking for S2. S2 is, look, widely split and does not change with the respiration. So it's fixed and split. And then we have the right bundle branch block. So on EKG, you can see this. The R waves, they're double R waves. You can see that. I'm highlighting, and then I'll make this bigger for you so you can see. Okay, but for now, let's just say yes. There you go. Volume overload. So people become symptomatic with ASD either in pregnancy or if they have too much fluid or exercise or activity where the demand for oxygenation increases, the demand for blood flow increases. And this question, I don't know if it says, let me see, comes to the office because of 6-week history of exertional shortness of breath. So exertional shortness of breath, that indicates that there is demand for increased oxygenation. So that'll be the clue to volume overload. Or if this was pregnancy, you can see that. What else? There's nothing else I will indicate, but look for that. Okay. All right, so that's the case. So our diagnosis would be atrial septal defect. That's our answer, but let's talk about the other ones. Let me change this. So when we talk about the other ones, then it will help us. Ductus arteriosus. Or remember, atrial septal defect is nothing more than, before I explain all of this, let me just do this quickly. Before I do more, not this, that's not what I wanted. How can I draw a square? Nope. I thought this will give me draw a square. Okay. Okay, let's say this is the heart. Okay, let's say this is the heart. If this is the heart, ASD should make sense. Right atrium, left atrium. Right ventricle, left ventricle. And what I will do is I'll color them blue so that we know right side is primarily blue blood. Okay, right side is primarily blue blood. And left side is primarily red blood or oxygenated blood, right? Why does he do that? I don't know. Okay, there you go. So now we have this setting. Blood comes to the right heart from vena cava, and from a vena cava blood will flow through tricuspid valve into the right ventricle. From right ventricle, blood will leave through the pulmonary valve, through pulmonary trunk. Okay, and then blood comes to the left heart through pulmonary veins, travels through mitral valve, and then from mitral valve, left ventricle, and from left ventricle leaves through aorta. And this is pulmonary, this is aortic valve, and this is the pulmonary valve. Okay, let me color pulmonary valve in green because that's important to us, and that's the one that's important for me to discuss. Okay, so that's the normal flow of blood. But now let's say there is a hole in the heart, and this hole is between the two atria, between the left and right atria. If the hole is between the left and right atria, where's my colors? There you go. So there's the hole. What happened? So hole is between, right here, there's the hole between the two atria. If that's the hole, then the issue here is as blood come to the left atrium, some of them is going to leave this way, and some of them will go through the left ventricle, and some will go to right atrium. So all the blood that was pumped by the right ventricle went to the left atrium, but from the left atrium, some of them came back to the right side of the heart, which means the right heart is now receiving a lot more blood than before. Okay, the right side of the heart is receiving blood from the entire body, plus a blood that it pumped, which is supposed to go to the left side of the heart and from left side to the body, but it's coming back to the right side of the heart. The reason for that is this is called left to right shunt, because earlier on the pressure in the left atrium is much higher than the right atrium. So pressure in the left atrium is much higher than the right atrium. So obviously blood will always travel from high pressure to low pressure. This is why this shunt is from left to right. Left to right. So this shunt is from left to right. So it's left to right shunt. So now this blood that's coming to the right heart is receiving much more blood than before, which means all of this blood is also going to go through into the right ventricle. From right ventricle, it will also travel through the pulmonary valve. So at the end of the day, there is much higher blood flow through pulmonary valve. So blood flow through pulmonary valve will increase. Therefore, pulmonary valve will stay open longer. Generally speaking, the pulmonary valve and the aortic valve should close exactly at the same time, therefore producing a single heart sound called S2. S2 is produced by the pulmonary valve in the aortic valve closure. But S2 has two components. P2, A2. P2 is for pulmonary valve, A2 is for aortic valve. Because both valves close exactly at the same time, you only hear one heart sound, which is S2 in this case, right? So you only hear one S2. But if the two valves don't close exactly at the same time, one closes too early, one closes too late, then there will be splitting of the S2. Okay, there will be splitting of the S2. Now in this question we have ASD has splitting of S2. Why is that? That is because the blood flow through pulmonary valve is increased dramatically, whereas blood flow through aortic valve is decreased dramatically. So less blood flow through aortic valve, much more blood flow through pulmonary valve. So pulmonary valve will stay open longer, aortic valve will close earlier. Therefore, there will be splitting of the S2. But guess what? The splitting of S2 does not depend on inspiration. It doesn't vary with inspiration. It doesn't change with inspiration. It's fixed. Make sure you remember that. Okay? Why do we need to say that? Because it's different than pulmonary valve stenosis. If there was a pulmonary valve stenosis, then the pulmonary valve, there will be splitting of the S2, but it will vary with inspiration. So that's how we differentiate between pulmonary valve stenosis and ASD. Okay, so at least we explained the S2 component of ASD. Now let's go to the murmur. Because there's increased flow through pulmonary valve, that means there's more turbulent blood flow to pulmonary valve, and that produces systolic murmur. Okay, because blood is pushed through pulmonary valve during systole. So there will be systolic murmur, and that murmur is usually systolic ejection murmur. You can hear really great at second intercostal space in the left of sternum. Okay, so we discussed now two things make sense. The murmur makes sense and S2 makes sense. And with time, so those are the acute symptoms. Chronic symptom of ASD would be as more and more blood comes to the right ventricle has to start push more and more. So if you have more workload, the muscle will hypertrophy. So right ventricular hypertrophy will occur with time. And if the right ventricle hypertrophies, the muscle becomes thicker. Therefore, sometimes a thick muscle and a thick myocardium, strong myocardium can compress or impinge the bundle branch and leads to bundle branch block. In this case, the right bundle branch can get blocked. When it gets blocked, then you will see a different R wave. Okay, a different R wave. So it explains that as well. So the right bundle branch block is due to right ventricular hypertrophy. Okay, And this scenario becomes symptomatic when there's volume overload, some exertion, some activity, because that's when increased blood flow will cause turbulence through the pulmonary valve, and in severe cases can lead to hypoxia and so forth, or cyanosis. Anyways, so that all of this is explained. Now let's go to see what are these other scenarios. How can we rule out everything else? Ductus arteriosus, choice B. Ductus arteriosus is a connection between pulmonary trunk and aorta. Ductus arteriosus is functional before birth. Why? Because before birth, we don't need to send blood for oxygenation to lungs. The fetus is receiving oxygen from maternal blood through umbilical veins, right? So therefore, you don't need to send blood for oxygenation purposes to lungs. So lungs are actually shut, so that you need to bypass that. And what caused this bypass is the ductus arteriosus. So ductus arteriosus should be open before birth. As soon as the baby is born and the baby takes his first breath and oxygen comes in contact with the ductus arteriosus, it starts closing down slowly. Okay? But if it stays open, it's abnormal. After birth, open ductus arteriosus is called patent ductus arteriosus. Patent stands for open. So PDA, patent ductus arteriosus, is not a normal thing. It's abnormal. It should shut down. It should close. But if it stays open, then you can have mixture of oxygenation, deoxygenation, blood, and of course turbulence, blood flow through that duct between aorta and pulmonary trunk. Because pressure in aorta is much higher than pulmonary trunk, so there will be left to right shunt, and this will cause continuous machine like murmur. Okay, so continuous. So this will cause continuous, not systolic. Our murmur was systolic murmur, so continuous machinery like murmur. And this murmur is where? Around the clavicle. Okay, murmur around the clavicle, not in the second intercostal space. So it is unlikely for this just based on murmur. Plus, ductus arteriosus does not have splitting of S2. So we're not going to choose B. Let's look at VSD. So VSD will have holosystolic murmur, just like this one. I'll put HS, okay? Holosystolic murmur, HSM, that's holosystolic murmur. But it is much lower. It's at left lower sternal border, not in the second intercostal space. Plus, with VSD, S1 and S2 will be faint, not split. Faint S1 and S2. But in ASD, I should have told you that S1 is normal, but S2 is much. S1 and S2 will be loud. Okay, especially S1. So okay, so that's for this. That's for VSD, and VSD is usually in children. Okay, so VSD will be in children. I'm going to erase this so I can do this. VSD is in children. PD is in children, and our patient is a 22-year-old man. So that in itself will rule it out. Now, pulmonary valve and tricuspid valve. Pulmonary valve stenosis, only pulmonary valve stenosis can produce systolic murmur. So let's say this is pulmonary valve stenosis. Pulmonary valve regurg will produce diastolic murmur. We're not going to think of that. Even the question is not telling you whether it's stenosis or regurgitation. So choice D, pulmonary valve. If it's involved, then we should think of pulmonary valve stenosis. In pulmonary valve stenosis, what do we hear? We would hear the same thing as in this person, right? It would be holosystolic murmur, or systolic ejection murmur in the pulmonary valve. Okay, so I can put holosystolic murmur or systolic ejection murmur, doesn't make much of a difference. And this will be in the second intercostal space. Okay, and it will be at the left upper sternal border. Okay, so this murmur is almost so far identical to the murmur that's produced by ASD. What's the difference? The murmur in pulmonary valve stenosis is it increases with respiration or inspiration. Murmur intensity increases with inspiration. Okay, so that's the difference. Whereas the murmur with with ASD is does not vary. So next thing, also in pulmonary valve stenosis, we will have S2 that is split, that is wide split, or you can say split. Okay, it is split, but guess what? It also varies. It's not fixed. It varies with inspiration. Actually, with inspiration. So this is what makes it different. Inspiration. So I'm going to color this for you so you can differentiate. You don't get confused. Both pulmonary valve stenosis and ASD both have what? They have S2 that is split. The difference is in ASD, the splitting does not vary. It's fixed. It doesn't vary. It doesn't change with inspiration. Whereas with pulmonary valve stenosis, S2 varies with inspiration. Okay, so that would be the biggest clue. Otherwise, they're both the same. And of course, in ASD, pulmonary valve is normal. It's not stenotic, it's not stenosis, or it's regurg. So it's just there's increased blood flow. Tricuspid valve. So far, this is not answered, this is not answered. And then tricuspid valve, again, tricuspid valve, the only time tricuspid valve can produce systolic murmur if it's regurg. And if you have tricuspid valve regurgitation, you will have polysystolic murmur in the fourth intercostal space at left lower sternal border that varies with the inspiration. In our question, the murmur is fixed and doesn't vary with respiration. So hopefully this answers the question. The next thing is I wanted to make this a little bit bigger so you can see the EKG. There you go. So EKG. You can see the R waves. You can see the R waves. So you see the R waves? They're doubled. You see that? They're doubled. And that is indication of right bundle branch block. Okay? Right bundle branch block. So you can see right here, the R wave is doubled. Here, the R wave is doubled. Here, the R wave is doubled. These are called the rabbit's ear and so forth. And you can see it right here too. R wave is doubled. R wave doubled. Okay. It doesn't matter. Anytime you have a right bundle branch block, you will have double R wave. It's not only with ASD. Anytime you have a right bundle branch block, like in pulmonary embolism, for example, or some drug. Okay. All right, let's go to next question. Okay, so next question is, a 60-year-old woman is scheduled for coronary angiography with stent placement in the left anterior descending coronary artery. Prior to the procedure, dual antiplatelet therapy is initiated with aspirin and drug X. Drug X inhibits platelet interaction with fibrinogen. Which of the following is drug X? This is, okay, so whenever I look at questions, I think of it two ways. Are they testing a concept or are they testing my memory? So in this case, they're simply testing your memory. Any drug that inhibits, let me just go to do this, there you go. Any drug that inhibits platelet interaction with fibrinogen, that's what they're looking for. Which drug is that? If you have your memory, let's go with our memory first, and then we'll go with the concept, understanding of the concept. So let's look at these drugs. Now let's go with E. In E, dipyramidamole. this medication. Okay, so this medication inhibits phosphodiesterase. It inhibits, I'll put the negative signs, phosphodiesterase 5. Okay, phosphodiesterase 3. Okay, so inhibits phosphodiesterase. And if you inhibit phosphodiesterase, cyclic AMP will increase. Cyclic AMP will increase within cells. If cyclic AMP increases, therefore intracellular calcium will stay low. Okay, it will, and then, but calcium is required for degranulation of platelets. Degranulation of platelet. So if you inhibit phosphodiesterase, I'm going to tell you quickly and then I'll erase it. Look, phosphodiesterase is an enzyme. So when you take, in this case, it's, let's say, ATP. ATP is converted to cyclic AMP by adenylate cyclase. AC output, adenylate cyclase is an enzyme that converts ATP to cyclic AMP. And when cyclic AMP is activated, this can cause downstream many reactions. Okay? In our case, increased cyclic AMP leads to decrease in calcium secretion from sarcoplasmic reticulum. So it leads to decreased calcium. When you have decreased calcium, guess what? Platelet needs calcium for degranulation. In the endocrine and nervous system, you should have memorized it. You should have understood this. All degranulation, neutrophil degranulation, all white blood cells, let's say in the nervous system, like neuron degranulation or vesicular release of their content or neurotransmitter, requires calcium. Exocytosis, degranulation requires calcium. Simple as that. So if the calcium is low, then there will be no degranulation, no exocytosis of the content that is stored within those vesicles. All right. But on the other hand, you can convert cyclic AMP. Okay, so cyclic AMP can be converted by phosphodiesterase 3. Phosphodiesterase 5, which I mentioned earlier, is usually used for conversion of cyclic GMP, not AMP. So it converts that to AMP, therefore decreasing the concentration of cyclic AMP. Okay, if we block phosphodiesterase, that means we are unable to convert cyclic AMP to AMP, therefore cyclic AMP concentration will stay high. Okay, it will stay high. That's what the mechanism of dipyramidamole and celestazole, both C and E are. Okay, so at the end of the day, remember that low calcium, low degranulation. If you don't degranulate, platelet cannot release its content, therefore thrombosis cannot occur. Okay. All right, so I'll put degranulation is inhibited. And this is the same thing as for celestazole. I'll leave it the same. Okay, celestazole is the same thing. Clopidogrel. Clopidogrel is the next medication, let's say D. So the function of clopidogrel is it blocks ADP receptor. Okay, it blocks ADP receptor. Inhibits ADP receptor. The name of ADP receptor is P2Y12. That's the name of this receptor. Okay, so if you block the ADP receptor, what could happen? Well, this receptor is responsible for platelet activation. So you literally block platelet activation. Platelet activation. Okay. If you inhibit platelet activation, that means no thrombosis. Okay, so no thrombosis. Okay, so clopidogrel does that through inhibition of P2Y2 receptor. Celecoxib is an NSAID, but it's selectively COX-2 inhibitor. So celecoxib inhibits COX-2 only. And remember, the COX-2 is responsible. Let me change color so we can differentiate between that. So COX-2 is responsible for production. Okay, COX-2 stands for cyclooxygenase, right? Cyclooxygenase. It's responsible for production of thromboxane. I'm going ahead of myself. Thromboxane A2. Okay. And it is responsible for production of prostacyclin or prostaglandin I2, which is prostacyclin 2. Prostacyclin, and it's also responsible for prostaglandin E2 production. In short, the cyclooxygenase enzyme is responsible for production of thromboxane and prostaglandin and prostacyclin. Okay, but if you inhibit cyclooxygenase, that means you're decreasing thromboxane A2. You're decreasing prostacyclin, and you're decreasing prostaglandin E2. Okay. Now, thromboxane A2 is responsible for platelet activation. It's responsible for platelet activation. If you don't have thromboxane A2, platelets cannot be activated. So, activation of platelet is inhibited or decreased or blocked. If If you like the term blocked, sure, we can use that. Okay, so far, none of them, all these choices that I discussed, none of them involves platelet interaction with fibrinogen. So, abseximab is a monoclonal antibody. Okay, it's a monoclonal antibody, synthetic antibody that blocks. Let me use dark color so you can see that blocks glycoprotein 2b3a. Okay, if you block glycoprotein 2b3a, this leads to decreased aggregation. Normally, it's responsible for aggregation of platelets. Aggregation of platelets. If you block it, it will block platelet aggregation. Therefore, there will be no thrombus formation. So at the end of the day, all these drugs, all of them decreases thrombosis or blocks thrombosis. It blocks thrombosis. It blocks thrombus formation or a clot formation, thrombus formation, clot formation, whichever one you like. Okay, that's what it does. But their mechanism is different. Their mechanism is different. Okay. Now let's see if I were to draw a platelet. Here is the platelet. On the surface of platelet, we have, let's say we have a receptor, and this receptor is glycoprotein 2b3a. And then I'm going to say another glycoprotein 1b. Okay, glycoprotein 1b. So these are the receptors. And then platelet additionally will have receptor on the surface which is called P2Y2. So that's another receptor found on the surface of platelets. Platelet also have thromboxane receptor. Okay, now I'll just put TR, thromboxane receptor, or let's just say TX, just to say TXR. So it's a thromboxane receptor. Platelet will also have on their surface thrombin receptor. Thrombin is clotting factor 2, so I'll just put 2. So these are the receptors found on the surface of platelets. Okay, let's see what is the function of each. Glycoprotein, so let's draw another platelet right here, and there's 2 platelets. Okay, and I'm going to color it for you. 2 platelets, that's 1 and that's 2. So these 2 platelets have the receptor on its surface called glycoprotein 2b3a. Okay, guess what? This glycoprotein binds something called fibrinogen. So let's say fibrinogen is red. It binds fibrinogen. And this fibrinogen links the 2 platelets to which receptor? Through glycoprotein 2b3a. This is called platelet aggregation. This is called platelet aggregation. So we're talking about this receptor. I'm coloring it red. Okay, so red is platelet aggregation. Glycoprotein 2b3a involves interaction with fibrinogen. So when you have 2 receptors, one on each of the platelets, those 2 platelets will link to each other or attach to each other through connection of fibrinogen. Okay, so fibrinogen binds which receptor? Fibrinogen binds glycoprotein fibrinogen. Fibrinogen binds glycoprotein 2b3a. Good. So that's done. So this is involved in platelet aggregation. And our answer choice, remember that abseximab is the one that involves glycoprotein 2b3a inhibition or blockage, therefore decreasing platelet aggregation by attachment of fibrinogen. So that's our answer. The rest of them are not our answers. But let's go through the rest of them to see if we understand them. Glycoprotein 1b. Glycoprotein 1b, this glycoprotein attaches to VWF, von Willebrand factor. Okay, von Willebrand factor is responsible for platelet adhesion or attachment to basement membrane adhesion. So to what? To basement membrane of blood vessel. In this case, collagen type 4, basement membrane. You know that all basement membranes are made of collagen type 4. Okay, the only way you can have collagen type 4 exposed if there's damage to a blood vessel. Okay, so far we have two things. Fibrinogen is responsible for platelet aggregation. Okay, aggregation already here, aggregation, whereas VWF is responsible for adhesion. Okay, all right. Next thing is P2Y2. P2Y2 binds ADP. It binds ADP. When ADP activates this P2Y2 receptor, it leads to platelet activation. So I'm going to put a plus sign. So this leads to platelet activation. Thromboxane A2, when it binds to its receptor right here, let's say this is thromboxane A2, it binds to its receptor. This also leads to platelet activation. Thrombin also leads to platelet activation. Okay, so out of these choices, thromboxane A2, ADP, and thrombin, all of them lead to platelet activation. And what does platelet activation means? Platelet activation means that the platelet can degranulate, number one. Number two, it can express on its surface glycoprotein 1b and 3b. Sorry, 1b and 2b, 3a. Those are the receptors. So when platelet express glycoprotein 2b, 3a, that platelet is activated, it can aggregate. If platelet express on its surface glycoprotein 1b, this platelet can attach to basement membrane and therefore initiates a thrombus formation to seal that cut. And I'll draw a picture for you. So hopefully this makes sense. Now I will erase this. So this is platelet activation. Platelet aggregation. This is platelet aggregation through fibrinogen. Let's do one more thing. What is platelet? Let's see what is platelet activation. Okay. Then we can put all of these together and it will make more sense. Let's see, this is okay. So there you go, another platelet. So what is platelet activation? Activation. So when ADP binds to its receptor on the surface of platelets, this leads to platelet activation. So I'm going to put a plus sign. That's one way. When thromboxane A2 binds to its receptor on the surface of platelet, it leads to platelet activation. Similarly, thrombin, okay, which is clotting factor 2, thrombin. All of these guys activate platelet. When you activate platelet, what does it mean? Number one, activated platelet. So I'm going to write here activated platelet. Activated platelet will express on its surface glycoprotein 1b. Okay, glycoprotein 1b. Activated platelet will also express on its surface glycoprotein 2b, 3a. If you don't activate them, platelet will not have these receptors. And if they don't have these receptors on their surface, they cannot aggregate and they cannot attach to basement membrane. Non-active platelets cannot do thrombosis, cannot form a clot. Next thing is, that was one way of activation, right? Expressing these receptors on the surface. The next way of activation is if there is a granule. Let's see if I can change the color. Let's say the platelet granule is yellow. Okay, so this granule, whatever it has within it, let's say within it has serotonin. So this platelet vesicle will have within it serotonin. Okay, serotonin. I'm missing an O here, right here. Look, and it can produce ADP, release a lot of other stuff. So the next activation of platelet is when this granule bursts, opens, and releases its content in plasma. This is also only possible if the platelet is activated. Okay, and especially cyclic AMP remember, increased cyclic AMP blocks that. So Increased cyclic AMP will block that, for which we need calcium. Let's just say calcium is needed. We need calcium. So for degranulation, what do we need? We need calcium. And calcium was blocked by cyclic AMP. Okay, so this is how platelet gets activated, and this is why we use these drugs to prevent thrombus formation. Hopefully this was helpful, and I think this was the last question for today. Yeah, this is the last question, but before I end, let me tell you what is the purpose of all of this. So now that you know how thrombus is formed, for thrombus formation, you need platelet activation. Okay, so just quickly, and then we're done. So for thrombus formation, what do we need? Number one, for thrombus formation, we need endothelium damage. Endothelium damage. Number two, we need platelet activation. Platelet activation. Once platelet gets activated, then they can cause aggregation, right? Aggregation. And of course, clotting factor should be the third, but it's not in this question, so I'm not going to talk about clotting factor. Okay, so these are the things that are needed. Now, in this question, we need to understand what is endothelium damage, what is platelet activation and aggregation, and of course, how do you prevent that? Prevention is through these medications. And we already talked about these. So thrombus prevention, right? Thrombosis prevention or thrombus formation prevention. So our goal is to make sure we prevent this thrombus prevention. All these drugs prevents thrombus formation, but by different mechanism. Okay, by different mechanism. Okay, and that's what you do, especially like thrombus that can cause myocardial infarction. So generally speaking, let's say this is a coronary artery. Okay, so let's say this is the coronary artery. So this is the coronary artery. Within this coronary artery, you have platelet roaming around, right? You have platelet just swimming around. Platelet, let's use this blue. They're usually like this shaped cells. So these platelets are just circulating within your coronary arteries. Okay. As long as the endothelium is not damaged, these platelets will not get activated. If they don't get activated, they will not have those receptors like glycoprotein 1b and 2b on their surfaces to attach and cause aggregation. Okay, and they will not have the ADP receptors, and they will not have those receptors. Okay, only activated platelet can participate in thrombosis or thrombus formation. So in this case, in this question, they're telling you that this person was placing a stent. Stent is a rigid structure, a ring that you want to keep the arteries open. If you put a stent, number one, that you put a stent in those patients who already have, let's say, a plaque, a cholesterol plaque, right? So let's say there's a cholesterol plaque right here. And you want to put a stent. If you put a stent, that means you're going to cause damage to this cholesterol plaque, and it's going to release the whatever cholesterol they have, and those can be released. Plus, let me cause damage to it, so just to make it easier. So there you go. Let's see. This plaque is damaged. When this plaque is damaged, then that means there is a damage to endothelium, right? If you get damage to endothelium, the underneath endothelium, let's use gray, you will have these collagen fibers, which gets exposed. The collagen fibers gets exposed. The collagen fibers are usually covered with endothelium, and I'll use green for endothelium. The collagen fibers are covered with endothelium. Platelets have no access to collagen fibers. Why? Because they're covered with endothelium, in this case green. But in this area where there's endothelium damage, in this area, okay, in the area where the endothelium is damaged, right here, collagen is exposed. And let's do that. You know what? I'm going to do this. Imagine. Let me use this. Okay, there you go. So this area gets damaged and this area starts bleeding. So your blood vessels start bleeding. When it starts bleeding, that means now you have access to collagen fibers. So your collagen fibers are exposed. When the collagen fibers are exposed, guess what? The VWF that is floating in your plasma, VWF. Let's say VWF is a red circle. This is VWF. They're floating. This floating VWF now can attach to what? To collagen. Okay. Before here, in this area, it cannot attach because collagen is not exposed. Only when collagen is exposed, VWF can attach to it. Plus, the damaged area is rough. It has the sharp edges, and that can lead to when the next platelet comes. When the next platelet comes in and comes in contact with this area, and this platelet will burst. This plate bursts. Okay. So let's say this platelet gets damaged. This platelet gets damaged. It's going to release its content. So this platelet, when it releases its content, gets activated, and then it'll express on its surface glycoprotein 1b. And 1b can then attach to VWF. So this platelet now already is attached to this, and this platelet will get activated and will produce glycoprotein 2b. So 2b, 3a will attach to another platelet, 1b will attach to VWF. So as a result, we will have multiple platelets coming and then attaching to this area, and then attaching to this platelet, to this platelet, to this platelet, to this platelet. And guess what did we just do? We just covered the damaged area. We sealed this area. But when we seal this area, in the process we form the thrombus. And that thrombus can decrease blood flow because it's blocking the lumen of this artery. Okay? So we want to prevent that. That was the whole purpose of this. Hopefully this was helpful, and we shall see you next time. For now.